last, your moment to please enlighten us. As I said in the introduction, you're here today primarily because Blind Veterans UK came in to see me about a number of issues, but in particular about a new campaign that they're doing in relation to the misdiagnosis as PTSD of what is in reality often the effect of repeated, cumulative, mild traumatic brain injury on which you are an expert. And they impressed on me the fact that if this misdiagnosis occurs, then people who are actually suffering severely from mild repeated traumatic brain injury, if they are misdiagnosed as having PTSD, then they're getting entirely the wrong treatment. So can you start off by explaining to us the challenges that there are in distinguishing between those two very different conditions, given the similarities in some of the symptoms, and then would you open out in more detail about the work that you're trying to do?
Yes. Thank you. Well, I should preface this by reminding the committee that I know you've heard evidence, I believe from Professor Sir Simon Wesley, that mild traumatic brain injuries were the signature injuries in both our forces, also the Canadian forces and the British forces in our recent conflicts. So there is a significant number of our veterans who have these mild traumatic brain injuries. Now I'll move to this document, which you will have seen recently. It was just released in October, and I know that MPs, you will all have received it. This was put together by another charity with whom I work, the UKBIF, the UK Brain Injury Forum, and this was all about traumatic brain injuries. On one of the pages, there's a nice big color diagram that outline the signs and symptoms that are common for traumatic brain injury. And if you were to put that next to the signs and symptoms for some of the mental health issues that we've been discussing, PTSD, for example, they're virtually identical. So it is a big challenge for the medical practitioner to disassociate between the two, especially if they do not have access to the prior medical records. If they don't know that service person has had a traumatic brain injury in their past, and the service person hasn't actually told them, then they may be treating for PTSD, which is common to do, when in fact they should potentially be doing something different. So a big challenge is that the primary treatment with PTSD, as you are all aware, is cognitive behavior therapy, and that doesn't necessarily work with people who have sustained mild traumatic brain injuries. So just
to ask you, so if somebody were unfortunately misdiagnosed as having PTSD and given what would be appropriate therapy for that, but the mild traumatic brain injury were left untreated correctly, what could the consequences of that be for the person?
Well, I think very simply they will not get the efficacy of treatment that they would otherwise if we were doing
progressive sight loss, for example?
Yes, absolutely. If the treatment isn't working, the signs and symptoms, the effect will be much worse. Yes.
So can you just explain a bit to us in some detail about mild traumatic brain injury, what actually happens, and what sort of results it tends to lead to, and how the cumulative effect takes hold of people?
Certainly. Well, I think a good way to explain this is to take this to sport, actually, because we see about this a lot in the news. A big part of this document from UKBIF was about sport, and there we have the phenomenon of chronic traumatic encephalopathy, CTE, that we've heard about with the American footballers, and now with rugby players here in the UK, and we see progressive behavioral changes, primarily things like depression, which spirals, and in the worst cases, of course, that leads to, unfortunately, suicide. There are behavioral problems There are particular problems with dealing with one's family, one's community. We had a very good debate in the previous session about whether we should have a national center to which people would be sent, or if this should be dealt in the community. In cases like these, being part of that community is actually really very, very important. Being connected to one's family, getting help together with one's family is very, very important.
But also being surrounded by other veterans is important, and that might work better in the residential setting, might it not?
Absolutely, and I think there's an area for both, and my recommendation would be to have a center. I think that's actually a brilliant idea, but there needs to be regional support networks as well. I think that one national center isn't necessarily the answer.
Mm-hmm. Very good. And what would help practitioners correctly diagnose a veteran's condition? I'm going to ask you all this, but coming to you first, Michael. So assuming someone presents with all these terrible symptoms of depression, and of course the immediate reaction, particularly since PTSD has become so much, I hate to use the expression of vogue term, but you know what I mean without any disrespect. How would you be advising general practitioners to be on the lookout to avoid this particularly dangerous form of misdiagnosis?
Well, I think one of the big things that we need to start looking at is serial testing of the brain. So in my case, every year. In other cases, every 2 years, for example, we have an eye test. I think we should be doing a brain fitness test at the same time. It would be very, very, very simple to do. And the serial, by serially testing these people, so we do this either each year or every 2 years, we can actually start to see trends. We can start to see somebody declining in their mental health before it becomes very serious.
You said it was very simple to do. What is the technique? Is it a scan?
So there are no scans. Actually, don't. There are no scans at the minute. People are working on this, but there are no scans at the minute that will detect this. So you do it. It's a series of neuropsychology tests that are typically done. There needs to be more research in this area to be fair, but these are relatively well-known tests. I can see this easily being rolled out into GP surgeries for annual testing.
Thank you. Deirdre, would you like to comment on what you've heard?
Any specific aspect of it?
Well, I'm just saying, yes, namely how the people in your cohort could most successfully be educated to avoid this potential misdirection of diagnosis.
So I would suggest that there is a greater problem with missing the diagnosis in someone who has comorbid mTBI rather than necessarily misdiagnosing with PTSD.
Comorbid?
Comorbid means co-occurring.
Right.
So if someone is presenting with severe PTSD symptoms, with nightmares, flashbacks, hyperarousal, these sorts of symptoms, they do need to be treated for that. But what is often missed is, well, I say often, but what can be missed is the underlying additional diagnosis of mild traumatic brain injury, which can present with the kind of mental health symptoms of poor concentration, depressed mood, anxiety, etc. And psychiatrists, in order to be picking up on this, they've got to be alert to it and aware of the possibility when they're taking the history. If someone has recurrent traumatic head injuries, asking about what was happening at the time. Did they lose consciousness? Did they have any amnesia, loss of memory? So that would be alerting them to the fact that there may be something additionally going on here. I think there's a piece of work. The Royal College of Psychiatrists provides online modules for all sorts of disorders. I don't know what the uptake is for the online module for traumatic brain injury, but that's something that could be promoted. But of course you have the problem then, if you make the diagnosis, what do you do? So currently I would be referring them, we have a good neurology service in London that we can refer them for a neuropsychological assessment. But if they fall beneath the threshold for that service taking them on, that's another gap in service provision. Probably moving on to one of the other questions, for appropriate care for these individuals, because there are adaptations that need to be made to their treatment, as Michael has.
Before I bring Jonathan in, I know a young sergeant who served in both Afghanistan and Iraq, and a medic, and he survived being blown up in an armoured vehicle, and survived apparently without a scratch. But presumably the vehicle was wrecked, the crew was saved thanks to good equipment design, but presumably the fact that he is now having certain symptoms automatically really ought to lead him down being tested for something like this, should it not? And yet, until Blind Veterans UK came in and told me about this, and I told his family, I don't think it would have occurred to him. What can we do about that? Perhaps, Jonathan, any ideas?
So I think the first thing as a general practitioner is you need to think about it. So as Deirdre said, you will see somebody with a constellation of symptoms, and actually some of it is actually taking a good history. As Deirdre did describe, if I saw somebody, and I have, with head injuries, we would tend to refer for neurocognitive assessment, and for us, we've got a centre in Birmingham. In terms of the Royal College of GPs, actually, just by chance, we're just about to publish an educational module, which is actually done in conjunction with Headway, which is a head injury charity, which I've got the privilege to do the voiceover, and we've done this jointly, and actually we'll be incorporating sort of military and also some of the hormone changes that also occur. In terms of the rolling out, I think in terms of screening, I think everybody would say that we would want to see the evidence base for that, in terms of whether or not that was an appropriate way of doing it. But that's how we would do any sort of screening. It's not specific to this. And that would need to be seen in the context of obviously the other priorities which we as GPs have.
Thank you. Well, that was very useful.